Good morning, friends. Welcome to India's biggest weight loss challenge. Today, our guest is Dr. Bollavarm Vikas Reddy garu. So, he is going to take the session today. He worked with Medicover hospitals and performed more than 800 surgeries, knee surgeries, and 200 hip replacement surgeries. So he is very experienced in the treatments, as well as he is also a national level badminton player and also played cricket for doctors leagues and all. He treated sports injuries with very popular sports persons like PV Sindhu, Kadambi Srikanth, Saina Nehwal, Pullal Gopichand's wife, Pullal Gayatri, and Pranavi, Gopichand's daughter. She is 19 years girls, and he have lot of experience. So welcome, Doctor Vikas.
Hi.
Yeah. You can start. You can share your PPT.
Yeah, I'm good. You guys get that? Are you able to see me?
Yeah, we can see you, but not the PPT. Just you can share the PPT. Yeah, we can see that.
Okay. Hi, everyone. This is Dr. Vikas Reddy. I'm a consultant orthopedic surgeon at TX Hospitals, Banjara Hills. I have been practicing for the last 12 years, and I'm more interested in sports injuries, as you can see through my resume. I was an ex-badminton player, and I cannot stay without sports. So right now playing golf, which is my passion right now. At some point of time, I have developed interest in sports injuries, apart from all the orthopedic surgeries. Right now, practicing more of these ligament reconstructions, shoulder reconstructions, and repairs. So today I've been asked to talk about the complications due to obesity in orthopedics. So hi everyone. Let's start today's presentation. So by the end of the presentation, you should be able to define obesity by its classification, understand the biochemical and metabolic effects of obesity, recognize obesity-related orthopedics disorders, discuss challenges in orthopedic surgery, evaluate post-operative complications, and review management and preventive strategies as you have to take away from the presentation that I'm going to show right now. So coming to the classification part of it, the obesity is based on the body mass index, which most of you might know, which ranges like this, where the BMI between 8.5 to 24.9 is normal, and anything above 40 is class 2 or class 3 obesity. So BMI is the widely used marker for distinguishing obesity and the muscle mass in the body. The most common problem is central obesity, which is mostly predominant in the Indian diaspora. So, as coming to the global burden, there are more than 1 billion individuals worldwide who are obese. Both developing and the underdeveloped nations both have these common factor that there are a lot of obese individuals. And now the during childhood and adolescence also obesity has been increasing quite rapidly because of the availability of the food and the carbohydrates that they consume and they take even during their childhood. Coming to the relevance in orthopedic surgeries, there is higher incidence of degenerative joint diseases, increased fracture complexities in the sense it will not break simply. Simple fractures are different. Complicated fractures with multiple bone fragments are difficult to fix. So this is one of the common reasons because of the body weight. They tend to fracture into multiple pieces. And due to the body weight, the joints also, which is predominantly the knee joint, wears out quite early than usual, which is more than 60-65 years. Now we come across because of the obesity part of the patient, they do come in with when they are 50-55 years, which is very young. So making the implant last for 20 years is a challenge because of their body weight, which is because we use polyethylene, which is plastic in between the two metal joints. Hence, the poly wear, the plastic wear in between the two metals increases if you are overweight. I'll come to that in a bit. So this is the world map where they show where the prevalence of obesity is the most. This is a 2025 study where America seems to be the highest individuals, highest people of obese individuals, followed by the Arabs and the South Americans also. Indians are as you can see, it is not as alarming as in the geography, but I do see it is catching up because of the metabolic, in the sense the food habits that we are being introduced to. So, by coming to the pathophysiology, there is a huge load on the joints when you are obese. Every 1 pound translates to 4 pounds of extra pressure on your knees and your ankles and your hip joints. So this in turn causes gait changes, malalignment of your spine. You might wear off one side of your hip or one side of your knee when you'll start waddling up and down. So these are few of the changes you observe when you are obese. So coming to the biochemical part of it, these adipokines are the part of the fat system in your body. So these adipose tissue, which is your fat, isn't just a storage tissue. It's an endocrine organ secreting pro-inflammatory cytokines. Pro-inflammatory cytokines are nothing but that generally cause inflammation in your body per se. Any systemic degeneration which happens in your cartilage will eventually cause your cartilage to wear off. Hence, you see more obese people having arthritis rather than the leaner people. Coming to the spine disorders, which you see during in an obese individual, is who come across with low back pain, lumbar disc degeneration, spondylolisthesis, and spinal canal stenosis. This is due to increased axial loading, in the sense because of the weight, the more of the pressure is fallen on the discs that act as shock absorbers. But there's a limit to which your body can take the weight. After which, all the biomechanical structures that help you maintain the alignment start breaking down, hence causing a lot of disc degeneration and disc bulges, which eventually might cause any nerve irritation, which might radiate to one of your leg. You might not be able to walk for a long distance. That is because of the disc herniation. Then there is for which you need to do some rehabilitation, and you have to strengthen your back so that your muscles are taken over the load that is being put on by the heavy weight of your body. So, as I've told you, fractures and trauma, there is increased chance of complicated fractures in the various areas where it might be a trivial fall or a high impact fall because of the weight, which may which may further cause multiple pieces of the bone to fracture, which will become further difficult for the orthopedic surgeon to fix. Any simple fracture is easy to fix by an orthopedic surgeon. A complicated multi-bone fracture becomes a little challenging. Then there is you need a high you need a high surgical skill to address these complications. You need specialized plates. The normal plates will not hold the body weight. They're designed for a certain body weight. So you have to use better implants, better metallurgy to be able to bear the weight which the patient is carrying. So coming to pediatric disorders, the most common pediatric disorders you see, which most of people don't know due to weight, is slipped capital femoral epiphysis, which is called SCFE, wherein your growth plate, which should be normal, like you can see in this image on the left side, which is normal, and to the opposite side, which is slipped. So that is a weak zone in your younger childhood. If you're overweight, there's more likely chances of your head, which is the cartilaginous part, to get slipped off its normal alignment, which further causes a lot of joint pain and limping, which further may eventually lead to avascular necrosis if not addressed properly. The Blount's disease is, as you can see in the image, this is overweight causing malalignment of your knees, which is more called bowed legs, which may happen even due to metabolic vitamin D deficiency and various other calcium deficiencies, phosphate deficiencies. But the weight itself will add to the worsening of the deformity. So coming to the foot and ankle problems, the most common things you find in obese people are knee joint pains, shoulder joint pains, your foot pains, and your sometimes you might lose your arch, which helps you move faster, run faster. So sometimes in obese people, because of the pressure, the arch flattens out, like you can see in the image, and this causes severe pain on the inside of your ankle, which is due to the stretching of one of the important ligaments which hold the arch up. So these are some of the common foot pains and problems that I see in the orthopedics OPD in obese people, which I treat with multiple physiotherapy and foot orthosis to regain their arches. So coming to sports injuries, which is I see commonly in my orthopedics, my OPD, the most common ones, obese people have ACL injuries. ACL injury is far simpler, but if you are obese, you might have multi-ligament. You might have an 3-4. Your knee generally has 4 pillars in your knee, so you might lose 3 pillars or 2 pillars because of your weight. If you just twist your knee and you're not able to hold your body weight against you and you suddenly twist around, generally there is a multi-ligament damage in an obese individual rather than a lean individual. So this itself causes, even if I repair it, there is delayed recovery. Generally, a lean person might get recovered in 2 months or 2.5 months, but an obese patient generally takes 6 to 8 months, which is a long time to recover from the multiligamentous injuries that I fix. Eventually, they do well, but the rehab and the process of coming to the doctor and getting evaluated every 1 month or 2 months as to how their progress is, repeated physiotherapy sessions for them to regain their normal strength is higher in an obese individual. So coming to radiological challenges, as you can see in the images, the obese people are mostly claustrophobic and they don't like closed spaces. MRI is a challenge for them. Getting into an MRI is a challenge for them. Due to their obese nature, they generally don't fit into the tube. Hence, wide bore MRIs have to be specially assembled by the top corporates or any diagnostic center, which again is a lot of investment for them. And doing any procedures through the radiologically guided procedures, since the since the fat percentage is high, reaching the target tissue to remove a biopsy or get a bone marrow or any tumor biopsy, it becomes a challenge because the needles might not be as long as that, or the depth perception of the probe might not reach to the level where they're supposed to go to. Hence, it becomes a little challenging in radiology if they are obese. So, coming to surgical challenges when in an obese individual, due to anesthesia is a risk because they're obese. The number of anesthesia required is high to maintain in that sleep state. Reversing them back to their normal senses also takes longer. They've got sleep apnea, which in there's lesser intake of oxygen, so the uh, the drug disposition doesn't match the requirements sometimes. As you can see, there is generally a lot of blood loss in obese individuals because the fat itself has a lot of vessel infrastructure inside it. Any surgical scenario where you have to go through a lot of fat tissue, it's a challenge for the surgeon because a lot of bleeding sites appear. You have to cauterize it. You have to wait for the bleeding to subside. You have to continuously ask the anesthetist to lower the pressures, which is a challenge for him per se. So all these things are a difficult scenario. They need special equipments to operate, as you can see in an image. And during a surgery, there may be scenarios where the table might fall away because of their weight. Positioning is different. The technicians around them are not equipped in Indian scenarios, as these are huge people. Putting them on the table for this position is a challenge for them. All these things are a scenario where it is very difficult to operate an obese patient in the OT. So coming to surgical challenges, there is, as you can see, there is the deep incision has to be deeper, longer to visualize the joint, which is further deep inside. And identifying the landmarks is a challenge. For some surgeries, you need proper landmarks to align the implants properly in the joint. If you're not able to identify where the appropriate bony landmark where you need to take an incision or put the implant changes predominantly, the alignments are a challenge. Even though we have trained enough to take care of all challenge, but it's challenge nonetheless. Handling the soft tissue is very difficult after the surgery. There may be dead spaces. There will be lipolysis after the surgery, wherein the fat starts to get necrotic and come off in the obese patients, which might look like pus for us, but we send for culture and it turns out to be negative. Then we have to the process of finding out for a leaky incision is challenging for the patient. The patient is anxious, surgeon is anxious. He doesn't want his surgeries to get infected. So these are some of the challenges during surgeries. So this after surgery, as I've told you, the most common and most feared complication is infection for a surgeon. Wound healing takes longer than usual in an obese individual. So we are scared that it's not going to heal, might break down. We might have to re-explore the wound and resuture things. And in an obese individual, if the implant is malaligned or if it's too heavy for the scenario wherein the implant fails by itself because the pressure of the person's weight directly translates to the implant in the joint we have put in. So it might lead to catastrophic failures. Sometimes we've come across quite a few of them in obese patients where we have to operate multiple times. The challenge is not to operate because we are trained to do complicated surgeries. The challenge is to convincing the patient that why it has happened. Some people are in denial. Some people are like you said that it will last longer. There are many more. There are many more complications that need to be addressed post-operatively, and if in a catastrophic implant failure comes, it's difficult for us to make the patient understand also to how the thing has happened. Then there are many chances of deep vein thrombus in this patient. So we do have to address them with medications after surgery to reduce the chance of clot formation in the lower limbs and the lungs per se. So as I've told you, these are some of the complications in replacement surgeries. Even though they cause huge relief after surgery when they have worn out joints, there is chance of infection because of the weight. They may dislocate. The implant might get loose. As you can see this on the right side of your screen. This is a knee where it's gotten loose because of the weight, and this is a hip which has gotten loose because of his weight. And there is generally a higher rate of complications in obese individuals rather than leaner individuals in joint replacement surgeries. So, as I've told you, these are also some of the complications in obese. There is most commonly there is varicose vein, delayed wound healing, pulmonary embolism, and implant failure. All these, as you know, in an obese patient might be diabetic. As Indians, I'm seeing every second in 3 people, every second person is diabetic and hypertensive. So the metabolic problem is increasing. Their health issues, apart from their obesity that they have, is increasing. So the complications during surgery have also increased. So how do I address? How do I tell my patient that you need to go for a surgery even though you're obese? If they're on the mid BMI or low BMI or just on the overweight side, we advise them to do muscle strengthening, back strengthening, quads and hamstring strengthening, shoulder strengthening, aerobic strengthening, cycling, cross trainer, swimming. These are the most common ones we advise. So then we advise, if they're too overweight, we advise them to go to biologics which help in weight reductions, or bariatric surgery that helps them lose weight, so that after the surgery they will benefit better. So how do we prevent this? Lifestyle modifications like physical activity, controlling your diet is the most important thing in losing weight. The most culprit thing as of now is food, the availability of food, the availability of carbohydrates. Every kid nowadays, during my childhood, there were sweets only during festivals, that to a limited amount, and any chocolates that came from America, which would be 3-4 years, once in 3-4 years. So nowadays, chocolates, desserts, the number of food joints that are being opened up with the name of gastronomy, or various tastes that suit your palate, have increased a lot. So availability of food has become a lot. So your comfort has become, even in your free time, you're thinking, if you're just free, you want to just munch on something which is either deep fried or any carb related or pastries. Gone are the days where you used to eat healthy food which had been made at home. Everything available is online. You can order in a jiffy. It's like 5 minutes. You can sit and have whatever you want at home. The availability has increased. Hence, the obesity per se has increased. So the remedy for these is either watch what you eat, find a nutritionist, eat healthy, be healthy. If you're not able to do that, there are easier ways to do it, but they'll have their complications, like drugs, which are the new drugs that have come in, Ozempic or Banjara or whatever, these GLP-1, GLP-2 drugs that have come in. If not, there is another scenario where you can go through a surgery, which is good and helps lose weight pretty significantly. So coming to my end of my talk, I hope you guys have learned enough of the problems in obesity in orthopedics. Obesity simply signifies a lot of impact on the musculoskeletal system. It increases the risk of osteoporosis, osteoarthritis, spine disorders, surgical complications. Weight reduction improves my outcome during surgeries, help manage me better, help have lesser risks after surgery. And to reduce weight, you need multidisciplinary action, either a surgery or medical intervention for them to lose weight. Prevention is the most important thing in medical practice. Hope you all do well. Thank you so much.
Okay, that was very, very interesting. Thank you, Dr. Vikas. That was interesting from many, many different ways. But I have to tell you,
Please.
It must be an absolute nightmare for you to undertake surgery on a morbidly obese individual, if at all that is possible.
I would rather, given the choice, I would say ask my colleague to do it. Please go ahead and do it. Please call me if you have a trouble. But as my profession demands, I cannot deny any patient. Any patient is the same. I cannot categorize them. I'm good at what I do. I know what I'm doing. It doesn't matter their body type. I'll have to manage whatever is given to me.
Well, of course, it's typical of you as a sports person to accept any challenge that is presented to you. But that does not take away the fact that it is an absolute nightmare. As I see it, as you mentioned it, this is the first time that I'm actually hearing about the problems related with the problems of an overweight individual or an obese individual in relation to surgery. It was very interesting. You also mentioned the diagnostic problems in terms of claustrophobia, getting into that MRI, positioning the individual. Now, that could also be problematic. You also spoke about the anesthesia impact. And most of all, post-operative improvement. I mean, you do the best you can, and then you're hoping that the healing is as effective as your surgery was, but you realize that the individual is himself, through his body structure, not quite as efficient as he would be. And that, you've used the word catastrophic failure, and that tends to put a lot of pressure on you. Am I right, sir?
Absolutely right. We don't want to see a catastrophic failure in obese individual, because the surgery after that is very long, very grueling. The recovery is longer. I still cannot tell him that everything will be all right even after I perform the revision surgery till another 6-7 months, till the implant survives. So it's very difficult to convince a patient with a catastrophic failure in an obese individual.
Okay, so which then brings me to my next point, where you spoke about weight management, and you said that perhaps the best remedy is to bring the individual back to normal size and then do the procedure. And I have to tell you, sir, that is probably much more possible now than it was in earlier years. For example, you mentioned yourself 2 or 3 relevant points. You spoke about lifestyle change, which you and I and the whole world knows is a lifetime of change. It doesn't happen overnight. But you presented 2 other options that were good solutions. For example, you said bariatric surgery. Now, in bariatric surgery, you can probably bring the individual back to a reasonable weight in a reasonable period of time, maybe 8 or 9 months, and then you look at the surgical options. And nowadays, in the UAE, for example, from where I'm speaking with you, uh, we have all the weight loss drugs available to us, which quite quickly reduces your weight. So then that would perhaps be a preferred alternative to you, that you suggest to the individual, you lose weight, it's currently possible to do that, and then we will look at the possibilities of orthopedic related surgery. Is that right, sir?
Absolutely right. But the medication part of it has its own complications. We don't know the future outcome of the GLP-1s and GLP-2s injections that people are taking. It's an easy fix, but the rebound is as bad. If you stop those medications and you've been hungry for 3, 4, 5, 6 months, you're going to go hog. You're going to hog like you've never hogged ever again. And you're going to put on back that weight immediately as possible. Bariatrics in that sense is excellent because there is the surgery itself doesn't let you eat as much. It still modulates the amount of food you eat. So I would say in a morbidly obese patient, probably bariatric surgery is much more advisable than taking the medication injections.
Yeah. So then it becomes a double jeopardy for the obese individual, as I understand you, sir, which means that you have a morbidly obese individual. And I can tell you that here in the Middle East, and you pointed out 2 countries, you spoke about America and you spoke about the Arabs, as you might say, which is the UAE, which is the country in which I am. Doc Vikas, you know, we've been doing this weight loss challenge over here in the Middle East for the last 5 years. And you're not going to believe this. Out of the 25,000 individuals that register for our weight loss challenge, more than 10,000 of them are in the region of 40 BMI. Now, that is huge. That is huge.
The census of 2025 didn't lie. The map didn't lie. It was
which perfect. Then means that surgery for these individuals is going to be so difficult until they don't lose weight, which then means that they need to probably look at bariatric surgery first and then look at any orthopedic remedy that could happen, which could be, I mean, it would be probably far easier if we looked at it from that perspective. And then, of course, you also spoke about not exactly the surgical aspect, but the very aspect of managing the load. And you mentioned that the load that an obese individual carries is multiple times more than the load that a normal individual would carry. And therefore, the human joint is not made to carry that burden, and therefore it degenerates much quicker. And therefore, and you pointed it out even in childhood, and therefore, obviously, obesity is a major issue for hips and knees and the spine and things, and ankles. You know, Doc Vikas, I have to tell you that I'm not obese. I'm a wee bit overweight, but I'm not obese. But all those things you spoke about, ankle, I've broken my ankle. You spoke about shoulder. Heavens, not more than a year back, I dislocated my shoulder. And then 10 years earlier, I went through that spinal thing that you spoke about. I mean, you know, Doc Vikas, I would imagine that perhaps a human cannot live without an orthopedic surgeon. It would seem that way because everything you spoke about in a routine way, I seem to have undergone. And I have to tell you that compared to the normal individual at the age of almost 80, I am extremely healthy, touch wood, and that's why I touch my head. You know, I'm extremely healthy and extremely and quite fit. But yet, I've been through all these protocols. So obviously, I have to advise all my friends and colleagues that, look, the best investment you can make is get in touch with and play golf, for example, with an orthopedic surgeon. Now that would be helpful. You'd kill two birds with one stone. One is you have the benefits of golf, and two, you have the backup of an orthopedic surgeon, and you're going to require his help at any time. Okay, now another interesting aspect of our discussion today. You know, Dr. Vikas, you have, I heard Coach Radim. I use the word coach. I should be using the word doctor. He's a PhD also, but he's also a coach. So I mean, you know, those of us who are in sport are extremely respectful of our coaches, and it's unfortunate that we are not living in America where the coach gets paid more than the surgeon. Can you believe that? The coach of a football team or the coach of a college institution is paid a higher salary than a professor. Coach Nadeem and I are, and you, sir, we are probably living, unfortunately, in the wrong country. But I do know some of the individuals that Coach Nadeem spoke about. Gopi was a young aspiring sports person when he came to us in the Tatars for an assignment, and he moved on then to become one of the most outstanding players and certainly one of the more eminently recognized individuals. And then you spoke about so many, Coach Nadeem identified so many other individuals. And the unique aspect of our discussion today is on your screen, ladies and gentlemen, on your screen, you have three champions of sport. Dr. Vikas, a champion, a badminton champion in his younger days, a national champion under 19. You have Coach Nadeem, represented India in hockey for more than a decade. And of course, with some, I'm looking for the right word. With some humility, I might add, you have me, national champion in the 100 and 200 meters, national record holder, Asian champion, represented the country. So we have three outstanding people over here. So you did mention golf. I have to tell you, Doc Vikas, that, you know, a lot of our friends play golf, but relevant to our particular event, which is the weight loss challenge. Only yesterday I was informed that the closing function would very likely be held at the Hyderabad Golf Club, which then means, Dr. Vikas, that you, whether we send you an invitation or not, and we will certainly send you an invitation, you would nevertheless be available, hopefully, to join us at our closing function. Now, Dr. Vikas,
my home course, I'll be there.
Thank you. You know, Dr. Vikas, you have done more than 1,000 surgeries in hip and knee, and that is remarkable. I say it's remarkable because it is now becoming more and more frequent. You know, I'm hoping, Dr. Vikas, that you and I continue to maintain a nice social arrangement where we meet each other in the evening for a drink or a meal or whatever. But I have to tell you that when I get up in the morning, the first thing I notice is that I have a bit of stiffness in the joint. Now, I'm hoping that that does not convert into a medical situation where I have to take advantage of our little webinar today by giving you a call and saying, Doc Vikas, I have a problem with my knee. Would you like to look at it? I'm hoping that doesn't happen. But Dr. Vikas,
it won't happen.
Thank you.
Being an active person, I don't think it'll happen.
From your lips to God's ears, sir. Dr. Vikas, that was a very, very informative, lecture, webinar, presentation. Call it what you wish. Call it what you wish. You know, you drew to our attention, and this was really the first time that it has happened. You drew to our attention the absolute difficulties that a surgeon would have when it came to operating on, successfully operating on an obese individual. Not just from the point of view of the difficulty the surgeon would have, but also in terms of the healing, which then means that obese individuals, to put it in a simple way, that obese individuals automatically reduce the efficacy of healing, and that is one of the risk factors that we must indicate in future, because we don't always talk about this, but medical solutions become far more difficult when the individual is obese, and that is something that you have mentioned. Dr. Vikas, thank you so much for a very, very interesting lecture. You have educated us, and you have educated our obese population on the absolute problems that they would face in case they need surgical remedies. But we are grateful to you for the fact that you accept the challenge like a good sportsman and would do the surgery in spite of the problems it presents. Dr. Vikas, thank you so much. Coach Nadeem, thank you too so much.
Thank you, Dr. Vikas, for a nice session. And I just want to give a last word. Like everybody who are listening to this podcast, changing your lifestyle in the beginning itself, when your BMIs are 25, you start working on stopping obesity and become healthy to avoid all the complications in the future. Thank you, Vikas.
Thank you. Thank you very much, everybody. Have a good day.
Thank you.